Thank you very much, Richard, and good evening, everyone. This is my heart, you can see on the screen here, and I can assure you, looking out over such a high-powered audience tonight, it is beating slightly faster than that at the moment. Image is everything. When I was putting the title for this talk together, I discovered that Andre Agassi, the tennis player, used exactly the same tagline in a 1991 marketing campaign for a Canon camera. But this backfired on him initially because it was a number of years before he won a major, and his critics accused him of being more interested in image than in performance. And, if you like, the impression that he was all style over substance. But tonight, I hope I'm going to convince you that certainly with regards to most patient journeys, with regards to making a diagnosis and coming up with a management plan for patients, the radiology image really is everything. However, for reasons I will discuss during the talk, the central role of radiology within all branches of medicine hasn't necessarily translated into radiology being taught at undergraduate level. So the premise of my lecture is really very simple. There is the image is everything tagline. Do we need more radiology education? Why am I convinced we do? And what is my evidence to back this up? And how do we go about developing achievable educational goals without reducing other areas within a very busy curriculum? And I've divided my lecture into three parts this evening. Firstly, I'm going to ask the question why radiology has traditionally been very underrepresented, as Richard has already alluded to from his own medical experience. And this is a worldwide trend, not just true to the UK. An inaugural lecture, by definition, has to centre around my journey to this role. And so in the second part, I'll discuss how I got into radiology and my interest in both medical education and medical politics. And in the final section, we'll explore the work I'm doing to try and improve education within radiology nationally. And then we will segue into a little section on medical school admissions and why I feel widening participation within medical recruitment is so important. Perhaps conspicuous by its absence in this talk is actually much mention of interventional radiology, my day job. Most of the clinicians here will know me for working in an interventional radiology lab, and I'm always happy to talk about the rise of image-guided surgery. But that is a different lecture. Tonight, we're talking mostly about what my work is with BSMS, although I will, however, reference IR where it overlaps with imaging education and research. So let's make a start. Is radiology underrepresented in undergraduate teaching? What do I mean by that? Well, radiology, by consultant numbers, is the second biggest consultant workforce within the NHS, second only to anaesthetics. We have a speciality that is important to every single other branch of medicine. And not only that, the attributes of a radiologist exactly, in my opinion, parallel to the knowledge, skills and behaviours required of our junior doctors at qualification. But for decades, as we've heard, the amount of radiology within undergraduate education has been minimal, if not non-existent. And having taught radiology now for 20 years, I've distilled the reasons for this into really three main themes. Reason one, radiology is developed faster and over a shorter time frame than any other speciality in medicine. A bold statement, I agree, but I will try and back it up. The second reason is that on the back of this technological advance, clinical pathways are developing faster than medical education evolves to keep up with them. And finally, reason three, a more nuanced one, which I'll go into in a little more detail. Radiology has often been considered as a postgraduate speciality, and with little undergraduate exposure or media representation, outdated stereotypes of what we do actually still exist. So let's take these one at a time. With the exception of plain X-rays, the vast majority of modern radiology has developed in my lifetime. Think of your own specialities or any branch of medicine, and there aren't many, if any, that can claim that within the last 40 years, everything we do has been invented. This is Wilhelm Röntgen, Professor of Engineering and Physics, who in Austria discovered X-rays in 1895, and the first X-ray ever taken of his wife's hand. This is a beautiful picture celebrating one of the pioneering women of medicine. This is Marie Curie, and most of you will know of Marie Curie from the work she did on radium and the development of radiotherapy in cancer treatment. What very few people know is that Marie Curie was the first to invent a mobile X-ray machine, and this is her driving an X-ray machine in a lorry that she took to the battlefields of the First World War and really revolutionised the medicine of broken bones and shrapnel injuries during the First World War. But after that discovery, very little happened. Ultrasound was developed in Glasgow in 1959, but really the images you would recognise didn't really come into existence until the mid to late 70s. Charles Dotter, pioneer of interventional radiology, performed the first angiogram in 1964, but again it was the mid-80s before interventional radiology really took up. The two big hitters of radiology, CT scanning and MRI scanning, were invented both in 1972, but it was the mid-80s before most UK hospitals had a CT scanner, and the mid-90s before they had an MRI scanner, and then PET came after that in the 80s and 90s. So you can see that everything we are now doing within a radiology department and have the potential to teach came into existence within my lifetime. The second reason is that clinical pathways are developing so fast. And I'm going to give you two very quick examples of this. I want you to imagine someone presenting to the emergency department with coronary artery-related central chest pain, so an MI, unstable angina. In 1971, the year of my birth, the grand total of your investigations presenting with an MI would have been an ECG and a chest X-ray. And we all know that the chest X-ray would actually have been normal and was obsolete because the three big causes of central chest pain being aortic dissection, pulmonary emboli, and coronary artery disease, none of them show up on a chest X-ray. Jump forward to 2025 this year, and within our armament, we have the beauty of CT coronary angiography. We have cardiac MRI, that's my heart again on the top, showing two beautiful images of it in systole and diastole. We have MIBI scanning, showing myocardial perfusion in various areas of ischemia. And of course, when we move into interventional cardiology, we have the advent of coronary angiography with angioplasty and stenting, PCI. Second example, change in bowel habit. Some of my colorectal colleagues are in the audience here this evening. In 1971, the grand total of the investigations, if you present with generalised abdominal pain or change in bowel habit, would be a skilled colorectal surgeon doing an abdominal examination, a PR with his index finger that would have detected approximately 20% of large bowel tumours within the rectum. You might have got a rigid sigmoidoscopy, which would pick up about another 10% of colorectal tumours. But that was about it. Then he would make a judgment call as to whether to take you for an exploratory laparotomy, some of which would end in a bowel resection, and some would be an open and close when he determined there was disseminated metastatic disease around the abdomen, and therefore you were unfit for any further treatment. Again, we jump forward to this year. Now we have colonoscopy imaging to diagnose tumours or polyps. We have CT pneumocolons. We have staging MRI scan for local staging at very accurate levels of stage 1 to 4 rectal cancer. We have distance staging through CT scanning. We have the wonder of PET, the most beautiful physics in medicine, in my opinion, that not only proves the existence of Newton's first law of thermodynamics, but also the existence of antimatter in one single examination, and was predicted, interestingly, in a 1965 episode of Star Trek, but that's another lecture. Let's look at the volume of CT and MRI activity over the last, this is 20 years, 23 years, from 2001 to 2004. Again, I ask you to look at your own specialities, the clinicians out there. There is no other speciality where the bread and butter of what we do, I'm not talking about the niche new procedures that come through research all the time, I'm talking about the general bread and butter of what we deliver has increased by 450% over 23 years. And there's a number of reasons for this. The increase in the technology and the broader clinical indications is one of them. The ageing population is important. The access, both from primary care and diagnostic centres, is important. But the radiology workforce has not kept up with this increase. And one thing we all know in all our specialities is when the workforce pressures get tight, often the first thing to fall by the wayside is the teaching component in all our job plans. Finally, on to reason number 3, and this is the more nuanced one. So I hear all the time, or used to, it's getting better, that radiology is a postgraduate specialty. Why do students need to know anything about radiology? If you want to be a radiologist, you'll apply to radiology as a postgraduate specialist. We're also very unfairly treated by the media. You don't see radiologists very often, and that all leads to outdated stereotypes. And this beautiful paper came out this year entitled Counting Coins in the Dark, which was a survey of medical students in Austria, Switzerland and Germany, and in a very high-powered journal, European Radiology. And they were looking at perceptions of what a career in radiology might be. And this was asking medical students. And the scatter plot of their word responses is quite shocking. This is what was highlighted, this lack of patient contact, the problems of artificial intelligence. Is it monotonous work, screen-based work, even lack of knowledge coming up as perceived issues of what working as a radiologist actually is? And so this proved perfectly my point, that at medical student level without the visibility, this is what they think we're doing, whereas this is actually what I'm doing. And this is the new interventional radiology suite looking over the coast in the new LMB building in Brighton at the moment. One of the problems we have as radiologists is visibility. For obvious reasons, patients that are sent for scans are given the results of their scans by the clinician in clinic that referred them in the first place, and that's inevitable. There's nothing wrong with that. But without visibility, with the general public not knowing what we do, it's difficult to get media traction to tell the good news stories of exactly what a radiologist does. And the media has also been slightly lacking in picking up on the importance of radiology in modern medicine. In-house, 60 to 70% of the complex diagnoses that he made involved imaging at some part on the patient pathway. And there was never a radiologist appeared as a main character in the series of House. House was so good at diagnoses, he even put his chest x-rays up backwards just to make it more difficult to make the judgment. ER aired for 331 episodes. There were 3 minor characters of a radiologist that appeared over the years. But if you think now about how the emergency department is dependent on radiology for the throughput of patients and for getting patients out and making a diagnosis rapidly, there is a big disconnect there. There is only one famous lead character radiologist in all of British TV drama. And he's perhaps not the greatest role model we ever had. Anyone that compares me to the great Alan Statham is, of course, quite ridiculous, because anyone that knows me knows that when I dance naked in my office, I'm playing the violin, not the recorder. But that just illustrates the problems we have with visibility. So that's the first part. That's laying the groundwork. Let's take it back now and talk through the journey as to how I got to this point talking about radiology. Well, I was born in Watford General Hospital in 1971, and here I am. And I knew that would get a reaction. Have you noticed how my BMI has gone down since I was born? I was born, I grew up, wonderful childhood in Hertfordshire. I didn't have any medics in my family. My mother, and it's wonderful that she's here this evening, was a geography teacher. My father, sadly no longer with us, was in banking all his life. I was the oldest of 3 children. Andy and Sarah here this evening as well. And apparently, at the age of 13, I decided I wanted to go into medicine. And I went through my usual schooling. I was at Mill Hill in North London. And then applied for medicine at the Royal Free Hospital. I'd got a friend's father recommended the Royal Free as a great experience for training. And I looked at the prospectus, liked the look of it. So decided to stay in London for my training. And for those that are interested in medical history, the Royal Free Hospital was the first and only medical school set up purely for women. In 1874, it went co-ed in 1947 after the Second World War. That's, of course, I'm not that old. That's not the building I trained in. That's the modern Royal Free Hospital where I trained in Belsize Park. And that's the picture on the far right there is the medical school entrance tucked around the back. And it was a very sad day for me when I was asked to go back and give a visiting guest lecture about 17 years ago. And as I turned up, they were up on ladders removing the Royal Free Hospital Medical School sign and putting up University College Hospital School of Medicine, because, of course, the Royal Free Hospital School of Medicine doesn't exist anymore. Anyway, I did an intercalated BSc in neuroanatomy, but my project was working with the great reconstructive hand surgeon Gus McGrowther, looking at lumbrical function in the hands. And I graduated in 1995, and I am that medical student that looks 12 at the age of graduation. And I was a relatively average medical student. I think I won a second-year prize in physiology, and I got a finals prize in surgery. But for most of the rest of my career, I was in that very safe second quartile that just drifts through medical school without any problems or raising my head above the parapet. What I was very honoured was to be awarded the John Glanister Memorial Prize at graduation. And that was voted for by both the student body and members of academic faculty for the greatest all-round contribution to the medical school. And I'll come round to how I think I got that award in a little while. I was amused when putting this lecture together to discover that I appeared on the front cover of the prospectus for the year after I graduated, 1995-97. There I am in the middle. Who says a radiologist doesn't know anything about complex airway management? There we are in action there in resuscitation training. Now, I draw your attention to this very nondescript grey concrete wall of the medical school. That is the back wall of the Peter Samuel Hall, which is the theatre of the medical school. I'm not talking operating theatre, I'm talking performance theatre, where I spent most of my time as a medical student. And we've mentioned my love of music. I think I did more music whilst at medical school than I did actually studying medicine. And I show this not to demonstrate that I did so much music, but just because this is a theme I'm going to come back to at the end of the talk, as to how music has followed me all the way through my career, and now is actually integrated with some of the outreach work and lectures that I do in public understanding of science and linking it to music. I took on conducting, as you've heard. That's me conducting the University College Orchestra. I directed a film whilst I was at medical school, sponsored by TVAM. They don't exist anymore. They were a breakfast TV channel when I was there. I even decided to join the TA and did 3 years with the Officers Training Corps at university. But coming back to that picture of the Peter Samuel Hall, a lot of the time as a medical student I spent on stage. And this is me starring and directing Guys and Dolls whilst at medical school. I apologise that all my friends are blacked out. Under GDPR legislation, the lawyers told me when preparing this that unless I get written permission for all my friends, they can't appear in a photo. So I've had to blank them out there. But they're all friends and colleagues of mine in medicine. And when we were preparing this talk, the professor of medicine, very austere gentleman at the time, came up to me. He was very proud of the musical that went out from the Royal Free each year and wanted to make sure it was going to be a good performance. And he always brought dignitaries from across London, senior medical figures and deans, because he liked to show off what the medical school was doing. So he called me into his office about a month before this and said, how's the musical going? It is going to be a good show, isn't it? And I said, well, I'm doing my best. I'm in the middle of quite a busy paediatric attachment at the moment. To which his reply was, well, don't worry about paediatrics. Just get the show right and make sure you pass the exam. So how things have changed in medicine. I want at this point to mention a great mentor. Mentorship is important in all our careers and someone that inspires us into the careers. And Bob Dick really was the greatest influence on my career. He was one of the founding fathers of interventional radiology and was the first radiologist to be awarded the gold medal from the British Society of Interventional Radiology. But I met him long before I planned to go into IR. He actually interviewed me for medical school, and he was president of the Music Society. So whilst I was a student, I had a lot to do with him. And he was very generous with his time and energies. He even volunteered to star in the film that I put together. I told him to turn up on Hampstead High Street dressed as a Russian spy, and he took me literally. And he got quite worried in my third year because I was doing so many stage performances and concerts and music that I was running myself ragged on public transport. And he even lent me his motor scooter to make it easier for me to get around London between all my engagements. He really was very, very generous. That was fine until I crashed his motor scooter in the wet outside University College. But again, he just dusted it off, said it doesn't matter. And that was just a testament to the generosity of the man. He sadly died in 2019 and will be fondly remembered. So a great mentor. And then, of course, I embarked on a surgical training rotation initially and was thinking about doing either ENT or upper GI surgery. And it was really his influence that I saw the rise of this new speciality of interventional radiology that inspired me to flip into radiology and then IR. So following graduation, I did what you can't do these days, which is put together my own surgical training rotation. So following graduation, I did my medical house job down in Winchester. I then went up to Glasgow for A&E. I did neurosurgery in Cambridge. I then went back to do my orthopaedics back to Winchester. I did general surgery up in Norwich. I then came to do ENT in Reading, and then back to Winchester for my first clinical teaching fellow. And it's no coincidence that I seemed to be being drawn back to the small Hampshire town of Winchester when I tell you that that's where Geraldine was living and working at the time. So all my jobs seemed to draw me back there. And then I applied for radiology training at the Royal Free, and at the end of that headed off to Vancouver for my clinical fellowship. Vancouver, an amazing city. That's Vancouver General Hospital. That's me in the IR suite operating. And it was great for a number of reasons. Number one, the European Working Time Directive is good for some areas of avoiding overwork, but they're not, they don't subscribe, obviously, to the European Working Time Directive in Canada, so they do work you hard. But what that results in is an enormous caseload during my year working there in general interventional radiology, but also some procedures that were at their very infancy in the UK. I got very well trained in Canada, fibroid embolization being one of them. It was only just starting out in the UK at the time, and I came back with very good case experience, and I set up the service in Sussex, both in Worthing and Brighton when I started down here. Vertebroplasty, a procedure to inject cement into the spine of patients suffering severe pain from osteoporotic compression fractures, hasn't really taken off. The evidence of long-term pain relief was lacking, so it is still done in some centres, but hasn't quite taken off like we thought we would. And similarly, very rarely see it these days, but when I came back from Vancouver, was the most experienced clinician in the whole of the UK in pancreatic islet cell transplantation with a massive 13 cases under my belt. It hadn't started here at all. And this was thought to be going to be revolutionary in the treatment of type 1 diabetes, where we take cadaver pancreatic islet cells and through an interventional radiology technique by accessing between the ribs the portal vein in the liver, injecting these islet cells which maintained alive plugged within the liver and were still producing insulin. And there were some very good early results on reducing severe hypoglycemia in type 1 diabetics, but it ran into problems largely because, of course, the immunosuppression required for it. It's a transplant of foreign donor tissue like anything else. The lack of longevity of the grafts, they tended to fade after about a year to two in the long-term follow-up studies. And, of course, the scarcity of donors, like with all transplants. So it is still performed. We don't do it in Sussex, but there have been so many other developments in the management of type 1 diabetes. This has kind of sort of fallen by the wayside a little bit. This is what I was most proud of in Vancouver, which I qualified as a Canadian ski instructor whilst I was out there. I used to think I was quite stylish as a skier as well. You see, this is just about to attack that. And I was walking down Steyning High Street about 20 years ago, and I saw someone had put an identical ski outfit in the window of the charity shop in Steyning. And I walked in and realised that it was, in fact, my ski outfit, which Geraldine had taken in, finally pointing out it was about time I moved into the 2000s with my ski gear. But anyway, that was me as a skier. And that brings me on to family very nicely. An inaugural lecture, you have to acknowledge the sacrifices that families give as we develop these careers. I married Geraldine in 2003. This was just outside, that was the day we moved into our first flat together in Finchley in North London. And Annabelle and Austin came along in 2005 and 2008 respectively. And this is Team Johnston taken earlier this year in the jungles of Costa Rica. Now, none of them wanted me to talk about them at all this evening, so I won't. Suffice to say that I'm very proud of them. So I was appointed consultant in 2005. I was originally a split-site contract between Brighton and Worthing before they merged. I made the mistake of carrying out the 3 life events in 3 weeks. I took on a new job, a new house and a new baby in a 3-week period, which I wouldn't recommend to anyone. And that was without any paternity or maternity leave for us, because of course we'd resigned from our previous job, so no one would give it to us. So we sort of muddled through and then started work in my consultant job. As Richard has said, I was appointed Director of Imaging Education in 2008, and that was the start of the journey with BSMS, integrating radiology into the curriculum. I was the IR lead. I've been the IR lead at Worthing really since I started up until the merger, and I was IR lead in Brighton between 2012 and 2019 with some successes. I started the regional on-call service for Sussex for IR. I really built up the interventional radiology service from scratch in Worthing when I started in 2005. And then in 2022, I was appointed to this post as Chair of Radiology. Now, I seem to have spent most of the last 10 years in committee meetings, and I'm not going to go through. There's a list of chosen committee meetings there, but 3 I just wanted to highlight because they become relevant when I'm talking about the work that I do within undergraduate radiology education. The first one is in 2018. I was appointed to chair the undergraduate committee of the Royal College of Radiologists, and that led to us producing the first national curriculum in radiology. In 2020, I became an executive officer of the British Society of Interventional Radiology, which I still am. And this year, I've just been elected to the Council of the Royal College of Radiologists, really to represent members' views and steer the direction of the college going forwards. I'm also proud that in 2019, I was awarded the Senior Fellowship of the Higher Education Academy. It's now called Advanced HE. And everyone in university life here will be very, very familiar with this, but the clinicians in the audience are probably less familiar with the Higher Education Academy or Advanced HE. And this is a professional and recognition and development scheme for educators. And it gives you both nationally and international recognised status for your work in education. It gives evidence of the impact of the work you've done. An area that was new to me was the exposure to adult learning theory and backing up your education with proper educational theory. And my submission, the thesis I put in for this, unsurprisingly, was on local and national curriculum development challenges within radiology education. And as Rich has alluded to, this is just testament to the part that I've developed my career on the education and scholarship pathway. And as he said, many of you will come to inaugural lectures on academic research, clinical research, and the 2 pathways, or 3 if you combine them in the central one, really do run in parallel within higher education. So that's my journey as to how we've got to where we are now. Let's take it back and talk about why I think it's so important to teach radiology at medical school, and why radiology is a speciality that has attributes that suit itself to a much broader type of education. Firstly, radiology underpins the diagnosis in 80% of patients that come through hospital medicine. It bridges, as I've said already, the medical specialties, the surgical specialties, even out into psychiatry and primary care. Radiology is central to clinical practice, and the teaching of it enhances communication between different teams. For early year relevance, junior doctors acting on imaging is critical, and particularly one of the main themes that the GMC put out in their outcomes for graduates is the managing uncertainty. And radiology and acting on a radiological report is central to how you manage a management pathway for patients. There are areas of patient safety that radiology naturally fits in with if you're talking about reducing errors in requesting and correct medical imaging, around students knowing what appropriate investigations to ask for with particular clinical conditions are. Radiation risks and the legislation or the legislative framework within which we work within medicine. And of course, developing clinical reasoning. It encourages problem solving and supports the evidence-based decision-making that we want to be central to our foundation doctors. And of course, back to the visibility argument, if students don't see radiology as a speciality, they're not going to be inspired to consider it as a career as they go forwards into the future. The problem, and this is no criticism to the clinicians in the audience here, is that when you take radiology education outside the radiology department, what most people think of is that. We're a little bit stereotyped that, yeah, we want a bit of radiology education, let's teach them how to read a chest x-ray. And that's the narrow framework of thinking that we're trying to expand and broaden out. And in 2016, I was asked by the Royal College to write an editorial. So worried were they at the lack of radiology mention in both national curricula and in medical school teaching timetables that they wanted me to really express a vision of where I think we should go to try and promote radiology in the future. And this in many ways was a call to arms to radiologists more than anything else to step up, who perhaps traditionally hadn't got involved in leadership roles within medical schools or universities and delivering the education that is so central to radiology. So what do I actually do to promote all this rhetoric I'm talking about today? Well, this document was a game changer. In 2019, the GMC published the MLA content map. I'm sure most of you are familiar with the MLA. This is the unified finals exam that every medical student in the UK will now undertake. As of last year was the first year that we ran this. And so it unified the playing field, if you like, that every medical school had to teach towards this standard curriculum, and it was therefore going to be assessed. And for the first time in a national curriculum, clinical imaging appeared as a separate entity. Now, what we'd struggled with for decades is that, of course, deans of medical schools, of course, are not going to promote in their curriculum anything that isn't assessed or specified, and that's quite understandable. You're not going to fill a busy timetable with something the students don't need to learn for their finals exam. But the first time, imaging and the conditions and presentations that were specified in this document, medical schools had to take this on board and start to work out how they were going to teach it. So that led me to lead the writing of this first undergraduate curriculum, which was published in 2022. And this looked, in the broadest sense, at how we should integrate radiology into medical school teaching. It looked at the knowledges and skills that were relevant within radiology that map nicely to the GMC. We looked at outcomes for graduates and, of course, the three main themes there, which again I think align beautifully to what we can teach in radiology, being that readiness for safe practice, managing uncertainty in clinical decision-making and delivering person-centred care, was central to how we approach this document. And it included both the knowledges and skills I've mentioned, individual patient tailored investigations, and of course what we've talked about, interpreting images. As the educationalists in the audience will know, there's been a global move towards competency and outcomes-based curricula, and so we based this on capabilities in practice around 6 main themes. And don't worry, I'm not going to talk you through the whole curriculum document, but this is the summary of the SIPs. So you can see how broad our appeal was. It was proposing and justifying investigation. So do students know, if a patient presents with X, what the appropriate investigation should be? Not really taught other than outside the clinical specialities. Can students explain imaging tests to patients? So this brings in issues of consent, issues of complications, issues of patient suitability for different studies. Number 3, where radiology education traditionally sits, which is just, can you interpret the X-rays? But I think equally important is SIP 4, can you base an action plan based on these imaging findings? We had one SIP just on the role of imaging to treat disease, so the rise of interventional radiology and where in clinical pathways interventional radiology should sit, and then a nod to emerging technologies. I'm not going to talk about AI at all this evening, but it is a massive discussion point, as you can imagine, within radiology at the moment. Now, a curriculum is pointless unless you have the assessment to go along with that. And in 2022, I was very honoured to be asked to be the only radiologist who sits on the Medical Schools Council Assessment Alliance item development group. So this is now taking the theory, the curriculum theory, and actually setting exam questions for medical school finals. And so for the last few years, I've been setting radiology questions to go into the medical school finals, but also am used to standard set questions that involve imaging from other clinical specialists to make sure they, A, show what they're alleging they show, B, that they're at a standard suitable for medical students that I think it's acceptable to accept medical students to be able to understand, and make sure that that it's relevant to the examination. It maps to the outcomes. On the back of this curriculum assessment and development work, it's led into a very nice education research project, which I'm right in the middle of at the moment. I've been working with the University of Sydney to develop teaching resources and do a big education project on effectiveness of education resources, but we're broadening it out much more than that. What we want to assess is student perceptions of radiology teaching, a little bit like that paper we did, but what we are now doing is seeing what students feel about the radiology education they get within their medical school, and then we're exposing them to a series of lectures that are mapped to the content map that I and colleagues have recorded, and I've written a number of examination questions, SBA questions, with interactive feedback that we're going to expose the students to and do pre and post questionnaires on quite what the student perception is on the need for radiology education, and we're hoping to roll this out next year, initially as a pilot study at BSMS. We're starting it here, but if successful, then we're hoping to do it as a study around multiple medical schools going forwards, because of course, without blowing my own trumpet, I think we're well ahead of the curve with radiology education at BSMS. Other medical schools, that isn't the case, and they still have very little radiology education. Now, if clinical radiology, which is all I've talked to up to this point, is important, I have long thought that imaging anatomy education is also important. And this is not part of the MLA. It's not specified by the GMC. But if you imagine that only 9% of graduating medical students enter a surgical speciality, that is, they will be opening up anatomy in front of them surgically, that means 91% of graduating doctors see their anatomy through imaging. And there is lots of evidence that if you combine traditional anatomy teaching with imaging, you have improved learning outcomes in your student population. This is a study going right back to 1992, showing that if you combine traditional dissection with imaging, you get long-term improvement in knowledge retention. And there's been two large medical systematic reviews, one in 2018, one in 2020, both showing exactly the same thing, that if you combine radiology imaging with traditional anatomy teaching, knowledge retention is improved. And I think there's an additional benefit that is harder to measure, which is the fact that if you expose students to imaging technology much earlier in their medical school experience, when they land in year 3 at clinical medicine, they already know how to orientate a CT scan, how to tell a difference between a CT image and an MR image. They're used to how we display our images. So there's huge advantages in improving learning going forwards. So from 2008, when I started here, we've really developed a collaborative curriculum between the anatomy department and imaging. And as you can see, I now deliver an imaging lecture with some colleagues of mine as well in every module of the Phase 1 course, which is mapped to what the anatomy team are doing in the dissection room. We do some dissection room tutorials, which the anatomy team lead, but again, they introduce some imaging themselves. And the students all do an ultrasound practical on themselves, so they get used to handling ultrasound probes and use it for surface anatomy and really get familiar with the technology. And a spin-off of this is I've been asked to write a number of book chapters on imaging anatomy. This was a great, we did 3 book chapters in this book with Professor Di Watts, who was the first professor of anatomy here at the medical school, and Julia Montgomery, consultant gynecologist, and we worked together and wrote 3 chapters. This is the College of Obstetricians Gynecology training book, where we wrote the pelvic imaging anatomy for future gynecology training. Now, one of my take-home messages of this evening is that career directions in academia often go in directions that you don't predict. And this was a wonderful study I was asked to be involved in. Roland Frey is Professor of Zoology in Leibniz, and David Reeby he's now back in France, but he was an expert in communication from the School of Psychology here at Sussex. And we put together this collaborative research project where I was asked to MRI and CT scan the larynxes and heads of 3 different species of deer, because they were doing a convergent evolution project looking at deer vocalization and how different species of deer have evolved to communicate in different ways. I should point out at this point that no deer were harmed for the purposes of this project. The deer heads we got were all part of the national cull of deer populations, which happens every year to control wild populations, and we had a license to take the deer heads from these culls and scan them. And so I did a lot of laryngeal measurements, vocal cord length of larynx, both on CT and MRI, which they got phenomenal results looking at how different species had evolved different ways of communicating, and it all relates to the evolutionary environment that these deer grew up in. And we produced some quite stunning pictures. I show you that just as a piece of art, not as a piece of radiology. That's not a photograph. It hasn't been photoshopped. That is purely a surface-shaded display reconstruction from a CT image of a red deer head. And I think it's phenomenal what technology we have these days. This was a lovely study with the anatomy department. This was led by Professor Smith, who's here this evening. And this was looking at 3D printing and whether you could use that to enhance knowledge in students. I was involved from the radiology side, and cadavers, the body donors that we have in the anatomy labs, have long previously been CT scanned, but up until this point they'd all been scanned after they'd been embalmed within the anatomy lab. And that does awful things for CT. It introduces gas into all the different tissue planes. You lose all the different density differences that you pick up on CT. So with Professor Smith's leadership, this was the first time an unembalmed new body donor had been CT scanned as we brought them into the anatomy lab. And then we did what we call segmentation, which is to subtract tissue other than a very specific density. And I've got 2 examples here of bone. And what you can then do is use this CT data set and program it through a 3D printer. Anatomy models are traditionally ridiculously expensive to get very good accurate anatomy models, but 3D printing is phenomenally cheap, and this is where the anatomy team took over, and they developed printing of models in all sorts of different parts of this CT scanned body, and then did this study on whether students found it useful in their anatomy education. So a lovely, neat project. This project requires no introduction. Many of you will have seen the Channel 4 documentary, again led by Professor Smith, My Dead Body. This was the tragic story of a young woman who died of a very rare advanced metastatic lacrimal gland cancer and gave her body for public dissection. And I was merely involved on the radiology side of the project, and that was both looking back, and we had permission to look back over all her scans she had during life to document the progression of the disease from the very first diagnosis through to her death, but also we similarly CT scanned this body on arrival and correlated what I found on the CT findings with what the anatomy team found in their dissection. And again, in a move that you don't expect in your career, I didn't expect to be sitting with the anatomy team at a table at the National Television Society Awards in London, 2 tables up from Kate Winslet, and because the director of this documentary was nominated for the Best Director of a Documentary that year. So a very humbling project to be involved with. I've done a little bit of other work with the BBC. A few years ago, I was approached by them to contribute to the BBC Bite Size. Those of you that are old enough to have teenage children will know BBC Bite Size as the GCSE revision resources that the BBC put out. And they wanted me to put together a learning resource on the electromagnetic spectrum. And that's me lying on the linear accelerator in the cancer centre in Brighton, a slightly disconcerting experience, I can tell you, with the planning lasers all lined up on me there to demonstrate the use of, obviously, the high end of the electromagnetic spectrum, the gamma rays, and its use in radiotherapy. That brings me on to public engagement. And again, I hadn't predicted a move into public engagement when I started off on my teaching career, but it's been a natural evolution. And I draw your attention to this seminal report that the Royal Society put out way back in 1985, referred to as the Bodmer Report. And this argued that the public understanding of science is crucial for individual decision-making, for societal well-being, and for democratic participation. And you can extrapolate that to the public engagement in healthcare. Again, I'm not going to run through all the advantages, but you can see how a better engaged and informed public are going to make better informed decisions about their healthcare, enable them to evaluate risks and benefits of medical treatments. It reduces what we're right in the middle of these days, the misinformation and mistrust around healthcare, and supporting public health measures. Now, I'm not for a minute pretending that I've made a meaningful difference in the public understanding of health or science. But what I have had is a remarkable response of positivity to a lecture series I've put together that I've taken round arts festivals, various places that have invited me to do that. And this is bringing back the music. This is what I want to talk about how music has come back into my career. So I put forward these lectures clashing together the performing arts, medicine and science. That's just a title of some of them, and have been given the opportunity to perform these lectures in some of the most astounding architectural buildings. And what I'm trying to do is just promote the public understanding of science, but do it through music and musical performance. This is taken from one of the talks I give. This is me on the MRI scanner up at the Clinical Imaging Sciences Centre on the Sussex campus here. And we were doing some functional MRI scanning on my brain's response to different styles of music, some of which I was very familiar with, some of which I was unfamiliar with. And the middle image is my functional MRI scan showing different areas of my brain lighting up to different types of music, whether it's familiar, unfamiliar to me. And I talk about neuroplasticity a lot, and neuroplasticity within health and following disease, and how music can enhance that. I'm not a music therapist, but I do talk about music enhancing health. And again, just some of the themes that I try and draw out. And I don't know what it is about bringing music into a science lecture that engages an audience. I think it's perhaps you just get a much broader cross-section of people that are interested in attending in it when, and I conduct choirs in it, I perform myself in them. We bring music as a central part of it. And what we've done is things from a musical and scientific approach to what is pitch, what is music itself, neuropsychological responses. And I don't just talk about positive responses, I talk about negative responses to music, how music's being used in torture, for example. So we bring in all sorts of themes. The anatomy of hearing, and then I sort of end up in the evolutionary biology of music and where music sits in cultural identity, but all looking at it from a scientific perspective. So that's been another area that I hadn't anticipated I would drift into. I just want to very briefly mention actually some clinical research. This has all been education up until this point, but I have undertaken areas of clinical research. One procedure that really I started to develop and have evolved is that of transjugular renal biopsy, which I'll show you an example of in a minute. Not widely performed. There's only about 4 centres in the UK. I do it here in Brighton, where this is taken off, but I was on the team that developed this back at the Royal Free about 22 years ago. Obviously, there are some multi-centre trials that I've been involved with, but also more recently, I see my role much more in medical politics rather than clinical research. This is a big paper I published with the executive officers of the BSIR more recently on where is interventional radiology going and what is our place in modern medicine. And I chair the interventional radiology committee at the Royal College, and we're wrestling some big themes that we're trying to get solutions to at the moment. One of the major problems we have in IR is the gender discrepancy at the moment. If you look at general diagnostic radiology, we're about 55% women at the moment. In interventional radiology, it's 20% women in IR. And so we're desperate to develop mentor schemes, ambassador schemes, try and really improve the visibility of IR for women as a career choice. We're looking at broadening our appeal into IR by getting entry at ST1 level. At the moment, you go into general radiology entry and then split at year 4. So we've started a pilot with the college to actually recruit from year 1, possibly thinking that we'll get people with a more surgical mindset earlier that want a procedurally based career. There's big discussion about whether we need a specialist exit exam, if you like, or certification for IR in parallel with all the surgical specialities that have an exit exam. And there's an ongoing GIRF review, the Getting It Right First Time review through NHS England or whoever replaces them, which is ongoing at the moment. So a lot of medical politics, which I've become involved with. I said I'd mention transjugular biopsy. This, again, I was on the team as we first developed this back at the Royal Free, and then subsequently have extended its role and applications working with Professor Louis Forney, Professor of Renal Medicine and Intensive Care in Guildford, where we looked to expand the use of it into patients in intensive care who often present with undiagnosed acute kidney injury. And it's a brilliant procedure. I thoroughly enjoy doing it. It's developed on the back of most interventional radiologists have got experience of transjugular liver biopsy. That's very broad. This is a modified technique. It's slightly more technically challenging. Patients always look at you slightly concerned when you say you're about to biopsy their kidney through their neck. But that is how it works. So we get access into the jugular vein within the neck, and I run a catheter all the way through the vena cava, take a right turn into the right kidney, and this you can see the sheath, the protective sheath we've got down into a lower pole renal vein. This is the contrast within the collecting system. And this allows us to perform the punch biopsy with the most exciting needle in medicine. How many other specialists have a 60-centimetre needle that I get to punch through the kidney? So that's the biopsy needle we use. But the big advantage of this technique is that I can then embolize the track by putting little coils down through a catheter to plug the track where we've taken the biopsy from to reduce the risk of bleeding. And we use these specifically in patients. The traditional way of getting a biopsy of a kidney is you just go straight through the back, directly into the kidney. But that is very risky for major hemorrhage in patients that have either abnormal clotting or complex vasculitides, inflammation disorders of blood vessels that make them more prone to bleeding. And so we use this specifically in that niche group of patients. And the study I did with Louis Forney was expanding that to whether a lot of patients get labelled with AKI on the ITU for various reasons, and it often gets labelled as acute tubular necrosis, ATN, but he quite rightly assumed that actually there's a subtlety within that as to what the cause of AKI is, and does getting an early biopsy in someone that crash lands with severe renal failure improve diagnostic pickup, and we published that about 8 years ago. I want to finish this evening just with a nod to my role as academic lead for admissions here. I was very honoured to get appointed to this last year. And my role is largely around setting the MMIs, so thank you in advance for those that have signed up to be an interviewer with the next cycle that starts in December. We still need interviewers for January for those that haven't signed up. And also I chair the admissions review group, which looks at the decisions on selection criteria, how we look at the type of medical student that we want to recruit. There's a bit of good news hot off the press here. We've had a 25% increase in applications for BSMS this year over last year, which is well ahead of the national trend. And this is partly, there's multifactorial, but one of the reasons is we've had a much more active social media campaign that we've been running this year. I recorded my first TikTok video last Friday with a one-take walk through the medical school, which will be released on TikTok, I think, within the next few weeks, as an encouragement to potential students that BSMS is the place they should apply for. What being admissions lead gives me is a vast array of metrics and data. And I'm not going to go through all these, but you can see the vast number of candidates we actually interview, how many interviewers we use every year. And this allows a move from just running admissions to looking at medical school admissions as an opportunity for some research as to how we improve the process. And so over the next couple of years, there's two main projects that I'm looking to get off the ground. One is mapping medical student selection criteria to in-course assessment, which is really very poorly being done. We know there's a strong correlation between a student's A-level results, particularly the science A-levels, and how they do at in-course assessment at medical school. There is moderate correlation between the UCAT scores, the pre-admission test that all medical students in the country do, but that's largely around just the verbal reasoning subset, much less correlation between the other subsets they do as part of that. And if you can believe it, all the medical schools in the UK largely use multiple mini interviews as their primary decision-making tool at admissions. And there is no large study or clear correlation between how students do in their multiple mini interviews and how they then go on to cope with and succeed during the medical school course. So that's one theme that I want to pick up going forwards, to actually look at MMI style, MMI content, bring in other medical schools across the UK and assess whether we are selecting students accurately to succeed on our course. Now, any discussion of admissions isn't complete without a nod to widening participation, and we are very proud in BSMS to have an award-winning scheme. Again, I'm not taking credit for this. The BrightMed is run by the admissions team here, and we go out to school children right from the age of year 9 through to year 12 with outreach work. I'm not going to go through them all, but you can see some of the engagement activities that we do. Again, I'm not going to talk here about the contextual data, how we define a widening participation student, but I'm quite happy to discuss it outside if anyone wants to. But we aim at BSMS, and we're one of the leaders in widening participation intake across the UK for 30% of our intake, so almost a third of our intake to come from a WP background. We achieved that at interview through 2022, so we interviewed 30% from a WP background. It didn't quite correlate to those that started, but I'm very pleased to say that for the last 2 years we have hit that 30% admission, and likewise I'm hoping to again. So let's conclude what I've been talking about. Radiology, both diagnostic and interventional, I think should be integral to medical school curricula as a means of teaching a much broader area of general medicine, surgery, and the specialities that bridge all arts of medicine. My request to the clinicians out there is stop thinking of radiology education as describing white blobs on an X-ray, and start thinking about what radiology can do to promote the scientific basis of evidence-based medicine, managing uncertainty in clinical decision-making, the mechanisms we've got through imaging techniques to demonstrate human anatomy and physiology through health and disease, and how we can help to teach patient safety, consent, the legislative framework of healthcare. The GMC have given us a framework, and the compulsory curriculum components that we to teach, but what I need to try and do is encourage the integration of this radiology teaching at medical school level. I've talked about how I think that introducing imaging early into anatomy programs, and we have a fantastic relationship with the anatomy team here, a lot of which is all integrated together. And you see some of the wonderful projects I've been invited to take part on by the anatomy team through this collaborative learning. And if there's one take-home message, particularly for the younger members that have turned up, career paths can't be predicted, so embrace the opportunities that are presented to you. Only through visibility of radiology teaching will the next generation of radiologists be inspired. Thank you very much. There's a couple of thank yous I must just say before we go. I would firstly like to thank Richard the Dean and Sasha the Vice-Chancellor for humbling me with their attendance tonight. I'm very appreciative of being there. There's one person I particularly in the audience want to thank, and that's the previous Dean, Malcolm Reed. Without Malcolm's drive for radiology, I don't think this post that I stand in now would exist. Malcolm and Juliet Wright, now Dean up in Guildford, were both instrumental in promoting radiology, seeing what I was trying to do in radiology and developing this post. There's a second reason I must thank Malcolm as well, and that's thanking him for retiring, because for the previous 12 years prior to that, I had forever been the second most important Malcolm in the room. So now, very occasionally, I'm the more important Malcolm in the room. I'd like to thank everyone here for coming, but most importantly of all, I want to thank my family over here. I appreciate taking on an academic career presents its challenges. I've mentioned all the committee work, the staying up late at night doing additional work. So I am very grateful for your support in this role. And now I finally will say thank you very much. And I would like to introduce Sasha Rosenhill, the Vice-Chancellor and President of the University of Sussex, to sign off.